Everybody, thanks for sticking around for this last session of the afternoon. If we can everyone just take a seat and settle down, we're going to get straight into a slightly shorter presentation this time. But what we're going to do is run about 20 minutes with our guests, and then we'll leave about 10 minutes for question time at the end. Once again, that applies to both those here in the room and to those joining us virtually using the Q&A function in your case, and in the room, just raise your hand if you'd like to get a microphone to you. Katlego, would you like to introduce our final guest?
Thank you, Pepper. Yes, let's do that. We came out of a session where we were focusing on disability income, and now we're going to change our attention and now focus on critical illness. The role of critical illness products has always been around meeting the changing lifestyle needs, as well as additional shortfalls in expenses relating to and following a critical illness event. And so the idea and thinking today is that we will hear some inputs from our presenters that will address issues like targeted treatments, wherein oftentimes shortfalls can arise. So, without any further ado, I'm going to introduce our speakers for this session, and the title of their presentation is Getting Back to Basics, Redefining the Role of the Critical Illness Product. And our presenters are KADENE GIBBS and Matthew PROCTER. Welcome.
Thank you. So actually, I wasn't expecting this many persons in the room, because the graveyard shift is kind of tough, right? So much so that I invited my husband and my daughter, just to make sure that I have at least 2 persons in the room. Well, I promise that our session will be short and sweet, and if there are no questions, it will even be shorter. So a very, very good friend of mine, she had a minor medical procedure a couple months ago. She said there was a bit of discomfort after the session, but for the most part, she was okay. I mean, she carried on with her life as if nothing ever happened. Now, it turns out that the event that led to that procedure qualified her for a 5% payout under her critical illness policy. With that payout, homegirl renovated her kitchen. Yes. Now, I am sure that we can all agree that the intention of life insurance is never ever to enrich, but to provide protection for persons when they need it most. Now, unfortunately, there are some aspects to the current product design that lends itself to exactly what we do not want: enrichment. So how did we get here? And probably more importantly, what do we do next? So the what we'll unpack a little later on. But in order to address the how, we have to look at the evolution and history of the critical illness products. Now, I'm sure we all know it was developed in South Africa in 1980. For the South Africa chance, do you say go box? Yeah? No? Okay. It was developed in South Africa in 1980. The original product consisted of 4 conditions, covered 4 conditions, with major severities all deemed to have significant impact on lifestyle. The intention of the original benefit was to ensure that persons who suffered one of these major illnesses would have been provided some sort of financial protection because they were unable to work. Now, fast forward a few years, and the critical illness product had grown massively as persons became more aware of the product and its benefit. But there were also 3 main things happening at this time that also had a very significant impact on the design of the product. 1, there was advancement in medical treatment, which meant that persons who would have suffered one of these severe critical illness was now faring much better. We had regulatory environments started to take shape, And this led to your standardized critical illness offering, your SCIDAP definitions as we now know it. But the South African life insurance market also started to mature. And what that meant was that you had your products such as your disability lump sum and income protection meeting some of the needs that the critical illness product used to fill. So what did insurers do in the face of all these changes? They adapted. They expanded the range of illnesses that they cover, but they also start tiering, and I mean T-I-E-R, not T-E-A-R, their payouts in order to align to severity levels. Additionally, because of the gaps that were being created by medical insurance, critical illness at this time became largely known as the benefit that would cover shortfall in medical expenses. Now, as the years progressed and the market grew, the critical illness product changed, but customers also started to get savvy. Like, now they had an expectation of what a severe critical event is, and then you had increased competition amongst your insurers. And this led to the design of the product as we know it today. Currently, your most comprehensive CI offering covers at least 300 conditions, with severity levels ranging from 5% all the way to 100%. And in some instances, we have reinstatement of certain covers, so you could get up to 300% of sum assured. We have standalone, we have no survival period on your standalone CI policy. So as you can see, quite complex. Now, in 2019, Hanover Re and one of its insurance partners embarked upon this journey to reimagine the market's CI offering by leveraging medical advances. And while the historical context was certainly important, for us, we had to ensure that we had a proper understanding of the current landscape in order to understand the factors that would influence our product design. Now, as we've seen over the years, medical advances have had probably the single biggest impact, not only on the design of the critical illness product, but also on its cost. So in 2019, when we had embarked upon this journey, what we saw was that targeted therapy was increasingly being used as an effective treatment option for patients. Now, targeted therapy is simply the use of specialized drugs, excuse me, to create a personalized treatment plan exactly to your genetic makeup and exactly to the disease. Now, targeted therapy, while very effective, is oftentimes unaffordable even for eligible patients. In the South Africa context, most medical schemes do not cover targeted therapy, and where it is covered, it's usually at less than 100% of the cost. So when I talk about expense, and I talk about something being expensive, what do I mean? Because clearly my expensive may not be the same as yours, right? If we take, right? So if we take, for example, a single dose of one of the very popular drugs that's used to treat targeted therapy or to provide targeted therapy treatment, we could be looking at 100,000 rand per dose. And now if we take, for example, say someone with a stage 3 melanoma cancer, and the duration of treatment that that person would require, we would be looking at treatment costs up to 3.5 million rands. Now contrast this against the fact that 60% of the South African market with CI cover have cover between 500K and 2 million. clearly suggesting that even persons with CI cover would not be in a position to afford targeted therapy based on the current product design as it is today. So in 2019, Hanover Re also did a CI market study. And what we see coming out of that study was that there was an increasing trend in the incidence of cancer, cardiovascular, and neurological claims. Now, these three claim causes account for roughly 60% of the risk costs on your comprehensive CI cover. So while targeted therapy can certainly be used to treat conditions from all three claim causes, for the first phase of our targeted therapy benefit, we decided to focus on cancer because of A, the relevance, and B, because at that point in time, it was the most researched. Now, I know I just threw a lot of information at you. My friend Slavitsa told me that this slide is extremely complex. So if I were to sum it up into 4 main points, let's see what we saw coming through from the current landscape. 1, there was an increase in the incidence of cancer claim. 2, targeted therapy is now being used as an effective treatment option for cancer patients. 3, medical insurance does not cover, or the options do not cover targeted therapy. And where covered, it's usually at less than 100%. And 4, for persons, even for persons with CI cover, they would not be in a position to afford targeted therapy based on the current design of the product as it is. And so here we were standing in 2019 with these 4 main factors coming through from the current landscape. And this gave us just an overwhelming confidence that a targeted therapy benefit, such as what we had in mind, would have a place in the South African market. So today, I'm actually quite pleased to be sharing the stage again with Dr. Procter. Matt, I didn't realize I was standing in front of you the whole time. Dr. Procter. So Dr. Procter was actually quite instrumental in the design of the product. So I've asked him to just share a few thoughts on the design of the product, the pricing, and probably more importantly, what's on the horizon. Matt.
Thanks, KADENE. I think you've done a great job of laying out the current landscape of where CI is. I think disclaimer from all the doctors who work in insurance, we take no responsibility for the parts of the product that you don't like, and we take all the credit for the parts that you do. So what I want to do is I want to take you through some of the principles of how we design this product. And I think what you will see come through is that this was not just a Hanover Re thing that we ended up doing. It was the combination of us as a reinsurer, but also we needed a willing partner. So our insurance partner was instrumental in co-designing the product and what the features look like. And there's also a key part of collaboration with pharmaceutical companies. And as you'll see in the pricing aspect, it's extremely difficult to figure out exactly how to price the benefit. But nonetheless, this was the result of actually an initial failed project looking at ways to incorporate targeted therapy as part of an insurance product. And obviously, as the doctor in the company, I confidently strode into an office with the actuaries, and I told them that we could definitely do this. In my mind, I had no idea how we were going to do it. But I knew that the need was there. And so these are the 7 principles that we followed. Number 1, the type of the benefit had to be a rider to a CI product. There are a couple of reasons for that. Number 1 is cost. It doesn't make sense to simply tell people to double their CI cover or triple their CI cover. It's already an expensive benefit. The second part is related to regulation, and that's linked to the benefit payout type, which is the second principle. Long-term insurers are not allowed to actually indemnify people, policyholders, for the cost of their treatment. So we have a rider which gives people optionality, and we also have a benefit payout type that avoids any regulatory pitfalls. Number 3 was quite a difficult one to address, I think. The types of cancers that should be covered. There were thoughts that we should only cover certain types of cancer because they're more severe. I think the problem with that is that cancer is a very emotional topic, and it's experienced very differently by different people, regardless of the type of cancer. So ultimately, all types of cancer are covered by this benefit. And then we get to points number 4 and 5, which is the claims criteria and the claims definition. Now, the claims definition, the claims criteria had to fit into existing claims processes. So for this benefit to be activated, you need to have a valid cancer CI claim to start. And from there, we then start looking at whether your cancer is able to be treated with targeted therapy. And that's where the claims definition comes in. It needs to be treated by targeted therapy. And very importantly, it needs to be a drug that's approved by the FDA, which is the Food and Drug Administration in the States. And we'll see later just how rapidly they are approving novel therapies for all sorts of treatments that need, or all sorts of conditions that need targeted therapy. In terms of the sum assured, it really didn't make sense to give someone a benefit that wouldn't allow them to access the treatment. So along with collaboration with our pharmaceutical partners, we realized that a minimum sum assured of at least $1 million would be required, and at the other end, we would need a maximum sum assured of 3 million rand. Again, we don't want the benefit to ultimately enrich people, but we also want to make sure that it's able to give people access to the treatment that they need. And then lastly, point number 7, risk management. We always need to be careful about what type of risk we're letting onto the books. And so underwriting principles or normal underwriting principles still apply. And at the claim stage, normal claims assessment processes also apply. There is also one key aspect that we included, which is an exclusion for off-label use. Now, off-label use is basically when there's anecdotal evidence that a certain FDA-approved drug could be used for a specific type of cancer, but it's being used in a way where it hasn't fully been proven out. And we had to include an exclusion to make sure that we didn't have the benefit being used essentially for a trial of therapy. And of course, as well, it's imperative for accurate pricing that we know and we have at least a good idea of when to expect claims. And obviously, if people are using things off-label, very difficult to do that. So, this is the fun part for the actuaries, I guess. Now, I wasn't quite sure if when we priced this benefit, if it was an actuarial nightmare or a dream. Because what you'll see is that it's basically assumptions on assumptions on assumptions, and it's all theoretical. So we've got no experience to look at. So, I don't know. We learned very quickly what types of personalities our pricing actuaries had in the team. So if you take total CI claims as being 100% of the claims, and for example, we say 50% of all our claims for CI are for cancer. Now, these numbers are made up for, and they're just for illustrative purposes. What we then needed to do was figure out what proportion of claims are made up by each cancer. So in the melanoma example, let's assume that it's 15%. So far, the pricing exercise is quite easy. This is where the challenging part comes in. What proportion of those melanoma claims do we expect both now and into the future would become eligible for targeted therapy? And this is where the fun part of theoretical research, certain assumptions, lots of discussions with pharma companies, lots of discussions with our insurance partners came in. And let's say, for example, that we decided that at the end of the day, we expect 23% of melanoma claims or melanoma cancers to be eligible for targeted therapy. We then end up with a weighted proportion of melanoma, which would be eligible for targeted therapy. So we would need to increase the risk rate in this example by 1.75%. Now we go through that entire exercise for all the different types of cancers. So this was a lengthy exercise, and ultimately we end up with a price for the rider that we believe and has proven out so far to be sustainable and affordable for policyholders. Now that was the part that we did for cancer. We can't stop there though. If you look at this graph, you can see that the novel therapies approved by the FDA are numerous, and they are not necessarily gaining pace I think that graph is reasonably flat, but the point is that these are just new therapies. So new therapies being approved by the FDA that are targeted therapies potentially and come with these significant price tags are continuing to come onto the market. And so you're going to see that the insurance gap can only get bigger from here. And these are not just therapies for cancer, these are therapies for other common conditions that we also pay for in critical illness products. So if we look at some of the costs of these things, they're astronomical. There's a drug that was recently approved for ataxia, which is a central nervous system condition that affects your balance, 7.4 million rand a year. And you don't just need 1 year of treatment. If we look at some of the common things we cover, in the metabolic category, diabetes, new drugs could cost up to 300,000 rand a year. Now, these may or may not be covered by medical schemes, but we don't know if they will be. Even things related to cardiovascular, you can see up to 2.36 million rand for 1 year of treatment, and these treatments tend to be ongoing. So, as you can see from this, the insurance gap will only continue to get bigger as these treatments advance, and the cost is still going to be with us for a long time. And in our constrained South African environment, it's imperative that we continue to innovate to provide this kind of cover so people can access these important treatments. Thank you.
No, I'm coming back. So what Matt didn't share was that our targeted therapy benefit actually went to market in 2021. And last year, we had our first valid claim. Man, we were high-fiving, fist-bumping, kicking each other. I mean, we were so happy because it's truly a rewarding feeling to take a benefit from concept to not only launching, but actually fulfilling a real need. Now, as we step into a future where customer needs will be forever changing and medical advances are happening at lightning speed, it will become more important for us to realign CI to its core purpose. I mean, our targeted therapy benefit was just one of the ways in which we did it, one of the ways in which we were able to innovate in the face of a new need, all while staying true to the core purpose of CI. It's not the only way. But by putting customer needs first, we ensure that we're not just changing lifestyle, but we're actually changing lives. Thank you. Now you can clap.
Well, just a comment in on the app from Jessica listening, saying, very cool product, thank you for sharing.
Thank you.
Do we have any questions from the floor? Yes, can we get a microphone to the gentleman in the maroon sweater, please? And anybody else? There's one here in the front and one over here. Great. Okay, let's start over here. This gentleman was first to raise his hand.
Thank you for the presentation, Alex Ruier. Two questions, just to find out whether you've taken this into consideration. Critical illness being quite volatile in terms of the risks and the costs associated with it, and therefore reinsurers historically have been very reluctant to provide long-term guarantees to those rates. And there always had been this debate between insurers and reinsurers about those guarantees. Customers want the guarantees, reinsurers don't want to give it, but that's not really what I want to ask about. Two things that I found years ago already. One was diagnostic trends. So technology also allows you to detect certain cancers a lot easier, making them a lot more treatable, whether you've taken that into consideration. And secondly, considering the cost of those medical treatments, they are exorbitant, but I suspect they may only be while those patents last. And I know there had been a lot of progress in the treatment of certain cancers, which is now very effective. At this stage, it's very expensive, but say in 7-8 years' time, when those patents fall away, wouldn't it become a lot more affordable, and whether you've taken that into consideration?
You want to take that?
Thank you. Yeah, so on the first question, definitely considered from a medical perspective. The potential shifts in early stage diagnosis as opposed to later stage One of the other considerations, though, is, and I'm going to make the comparison to HIV here. In the initial stages when antiretrovirals were first brought out, they were only available to people with a CD4 count of less than 200. Now we're at the point where you can get ART at the point of diagnosis. And something similar is already starting to happen for targeted therapy, in that the therapies are now becoming available at lower stages of cancer as well. So while, yes, we may be getting earlier stage diagnosis, the therapies are actually becoming more available despite the earlier stage of the cancer. And then the second question, sorry, I've gone blank, if you can just remind me quickly.
Once the patents expire.
Yes, the patents, sorry. Yeah, with regard to the patents, that is definitely something to consider. I think from our perspective, this is not a static benefit. So it's not static from the sense that we constantly review what is happening in the space. And while certain drugs may be generic in the future and therefore cheaper, I like to, it's not my analogy, it's actually an analogy from one of our pharmaceutical partners. He said that even though some of the treatments could become generics, if you compare targeted therapy to a Panado, for example, a Panado is like making a paper plane. A targeted therapy drug is like producing a fighter jet. So even though the patent may be gone, there are still significant cost considerations for actually manufacturing that drug, which won't go away. And the other thing is also that there will be newer drugs that continue to enter the market, which obviously will still be under patent. So we think that while those are definitely considerations, the benefit will hold its value for many years to come.
I think we have a question from the middle section, and then we'll finish off with Neo. I think you had your hand up, so there's already a microphone there.
Thank you very much for the presentation. So I just want to, I might have a follow-up question. So your sum assured, is it a defined sum assured per cancer type or per treatment type, or is it chosen by the client?
So in this particular instance, we worked with our insurance partner, and based on the target market also, we came up with a band that made sense based on the customers that we were looking at, as well as the targeted treatment that we would be aiming to provide.
But yeah, so the sum assured is chosen by the client, and it applies to any cancer that gets diagnosed.
Okay. Fortunately, we have time for one last question, and all right, I think that hand is satisfied now. Thanks, Neo. We can bring the microphone to the front and then take our last question there.
And if you don't mind, there was a last slide with our contact information, so if there are any follow-up questions, please feel free to reach out.
And we can fly to that slide as we take the last question.
Thank you. It's Sarah Bennett. I went to the oncology conference on the 1st of September, and it was very interesting as an actuary, but there are ASCO guidelines that they talked about in the presentations in terms of the gold standard of treatments, but unfortunately in South Africa we are not able to offer that standard of treatment in the public sector, and even in the private sector. I'm from the medical schemes industry, and we're not able to fund that gold standard of treatment. It will cover some of the drugs on the top options, but generally that gold standard of treatment is out of reach for most South Africans. So yeah, so I really support any initiatives that can help individuals fund this very expensive treatment. Thank you. Thank you for the presentation.
Thank you.
Thank you, everybody. That is where we wrap up our final session of the day. KADENE and Matthew, thank you so much for that fascinating presentation.
Yeah, man, thanks a
All
lot.
best to you. Give your mom a big clap. Yeah.
Thank you so much.
Thank you so much. Great to be with us.
We've gone to the end of the 50th ASA
Okay,
convention.
Katlego, I mean, it's been a fascinating 2 days. As I said at the start of the day, in some cases, it's been Greek going over my head. But what's really struck me in today's sessions is the amount of collaboration that's gone into these papers. We've had several papers where there's been input from all over the world, which is incredibly encouraging in terms of the sharing of ideas.
Exactly, I agree with you, Pepper. And I mean, actually, let me steal this moment and say on behalf of the attendees of the convention, our 50th actuarial convention here in South Africa, which is in our 75th anniversary celebrations for the Actuarial Society of South Africa. So on behalf of the leadership and the membership for the Actuarial Society of South Africa, thank you for joining us over the past 2 days. Shall we give a round of applause for Pepper?
Thank you. Thanks, everybody.
I know that you abandoned your work at Cape Talk. I hope that these last 2 days at least felt like Joburg Talk.
Well, I enjoyed having some Joburg sunshine at the very least.
Fantastic.
I'm sorry we brought the rain with us on the second day, and I'm sorry we made the traffic so bad for you for a few days. But to all the Cape Townians and everybody else from out of town, we wish you safe travels home again. Thank you for making the effort to be here in person. I'm sure everyone will agree it's been worth the trip. And for those who are resident in Joburg, thanks for allowing the hordes to descend on you. I just want to remind everybody, I know there's a big party happening at the top of the world later tonight. If you haven't yet picked up your wristband to attend that, you're not going to get through the front door. So please do so on your way out if you haven't already collected that. And we hope you have a great time letting your hair down a little bit after all of the serious business of the last 2 days, Katlego. Look forward to seeing some photos of you on the dance floor.
I'm sad we won't have you there, but I'm looking forward to seeing each and every single one of you as we have the cocktail event later tonight. Thank you for your attention and for your engagement throughout the past 2 days, past 3 days, for those of you that came for the Africa Seminar. Give yourselves a round of applause and thank you.
Thank you. And the very last thing to do is invite you to please stay and direct your eyes to the screens, because there is a closing video from your outgoing president, Chart Esterhuizen, and the new incoming president, Costa, which we'd like to invite you to stay and watch. Thank you.
We've come to the end of the 50th ASA convention in a year where ASA celebrates its 75th anniversary. How special is that? I think we can all agree it was a great convention with great papers, debates and plenary sessions. Thanks to all that attended and presented. Your participation and involvement made this event so much more special and engaging. As such, I also thank the organizing committee and Africa Agenda for putting it all together. Planning an event like this takes months. We appreciate the effort and the time put in to get us here. In particular, I thank Roxanne, the chair of the committee, the respective leads of the various work streams, Catherine, Chris, Logan, and Simon, the rest of the committee, and the staff of the ASA office under the leadership of Michelle. You've done a sterling job. Costa, as incoming president, I'm sure you also have something to say.
Thank you, Chart. I agree. It's been an absolutely brilliant convention. We've seen some great and very respectful debates. We've seen some thought-provoking papers, and we've seen some excellent presentations. Thank you to all of you that have made this possible and have made this happen. May the next 75 years see us not only lead, adapt, and thrive, but also lead with foresight, relevance, and innovation. Let's carry forward the legacy of excellence, commitment, and collaboration, ensuring our profession remains at the forefront of shaping a secure and prosperous future. Let's remain relevant to every South African out there. We're ending the convention in style with cocktails and a dinner event at the Aurum this evening. I'm looking forward to seeing everybody that has purchased their tickets this evening. Bring your dancing shoes. I have no doubt we're going to have a lot of fun. The convention would also not have been possible without our sponsors and exhibitors. I'd like to thank you all for the invaluable contribution you have made in making this convention the success that it has. I'm not going to read out all the names, but you can see them all on the slide. Without your support, this would not have been possible. Thank you once again. I look forward to seeing everybody next year in Cape Town. Until then, take care, be safe, and have a wonderful end to the year. Thank you.